This video will discuss the appropriate diagnostic pathway for chronic pelvic pain for women and people assigned female at birth.
I was 12 when I first started having pain and was diagnosed with endometriosis at age 30. It took me over 12 doctors to get a diagnosis of pelvic pain.
It took me 11 years to get diagnosed. I think that I was dismissed early on because I was so young and I had just started menstruating, and it was deemed to be something normal that maybe I would grow out of or maybe would kind of equalize.
The assessment of chronic pelvic pain begins with building a therapeutic relationship with your patient. This involves avoiding pain stigma, such as saying their pain is in their head, as well as validating their pain experience and actively listening with empathy.
I'd like to hear that they hear me. I'd like to hear that they understand. I'd like to hear that they might not know exactly what it feels like, but to have some compassion and some grace with me, because I might be really angry and frustrated because no one is explaining to me what's going on inside my body, or I'm having trouble articulating what's going on inside my body, because all I know is it feels like it's falling apart from the inside out.
I finally went to the emergency room one extremely painful day, and I did get an ultrasound and was diagnosed with a cyst. And when they removed the cyst, they found scar tissue from endometriosis that had glued my organs all together, my fallopian tubes to my uterus, to my pelvic wall. And I'll never forget that in my post-op, the surgeon said, "Wow, you were a real mess in there," as though she was just discovering it for the first time and hadn't heard me say for a year that I was almost unable to work and in daily pain.
It is important to assess for the underlying cause or causes of chronic pelvic pain. Chronic pelvic pain can have multifactorial contributors. A comprehensive history, physical exam, and pelvic ultrasound are essential for narrowing down the contributors to chronic pelvic pain.
I was diagnosed at 30 with endometriosis, but I'm sure that if any of my doctors earlier had decided to send me for an ultrasound, my endometriosis would have been caught much earlier and I would have not had to have suffered so long.
A comprehensive pain history includes asking about the initiating event, if something provokes the pain, such as moving or sexual activity, what the pain feels like, what the severity of the pain is, and what medications they have tried for the pain, and if they worked or not. The history should include asking about the type of pelvic pain they experience. Is there pain with menses? Pain with sex? If there is pain with sex, is it deep in the pelvis or superficial at the vaginal vestibule? Is there pain with bowel movements or urination? To further help identify the possible contributors to this pain, ask about infertility, pregnancies, history of sexually transmitted infection, past medical history such as history of pelvic surgery, and family history such as family history of endometriosis.
It was always period focused. It was never beyond just what my cycle was. So it was just like, well, you're just having a hard time with your period, that's normal. And I was always like, it's not normal to me, so we need to do something. There needs to be a curiosity around pelvic pain that digs deeper than just what we know on the surface. I wish that there were questions asked about the other systems of the body that feel affected, what the toll is on my daily life. Am I experiencing this? How frequently? Is it every day? Is it all the time? Is it parts of every day? I don't think that there's a curiosity about pain because pain is such a widespread and nuanced thing.
Chronic pelvic pain affects the physical body, but also affects mental and emotional faculties as well. It is important to ask about the mental health impact of this pain and the impact on quality of life and daily activities.
I really wish that some of my practitioners had said, it's okay if these things that we're trying don't work. We understand that you're still in pain and we are with you for the journey of figuring out what it is. A patient needs to hear, we hear you're in pain, we believe you, now let's look to confirm it, and we're doing that together.
things that aren't helpful is it's all in your head. It's all in your head. I'm saying that again because it's really, really important. Just take the painkillers. There's nothing else we can do. You talked about this last time we were in. I thought we dealt with this. I think when a practitioner asks about my pain, I don't want them to just focus in on the pain. I want them to ask me about and listen to me when I talk about how it affects my daily life. See me as a whole person and not just a pelvis with pain.
Vitals and blood tests should also be done. Consider ordering a CBC, creatinine, and ferritin for this patient. Additional blood work can be added depending on the patient's symptoms and history. If bladder symptoms are present, then a urinalysis should also be done. An essential component of diagnosing the underlying cause of chronic pelvic pain is a physical exam. This should include an overall assessment of gait and screening for pelvic girdle pain, pelvic asymmetry, and a hip exam. The abdomen should be explored for masses and hernias, as well as localized tender areas using the Carnot's test to identify abdominal wall pain. Clinical findings suggestive of central sensitization, nociplastic pain, include allodynia and hyperalgesia. Allodynia is the presence of pain from a non-painful source and can be assessed with a cotton swab drawn across skin. This should be done on the abdomen. Hyperalgesia is excess pain from a painful stimulus. Widespread pain in the location away from the peripheral pathology is suggestive of central sensitization. A pelvic exam should be offered, if tolerated and after a consent discussion, for people experiencing chronic pelvic pain. Ensure the exam is trauma-informed and patient-centered. Pelvic exam should include offering a chaperone, permission consent to proceed with the pelvic exam, and frequent check-ins during the exam. These exams can be painful for patients with chronic pelvic pain. Preparing patients for these experiences can be helpful. Pain management strategies should be discussed with patients like NSAIDs and heating pads.
The best pelvic exam experiences I've had are with providers who seem confident and know what they're doing, who tell me what's going to happen completely before they start, and then walk me through every step as it's happening, giving me lots of time to say, no, stop, wait, I'm uncomfortable, or what are you doing, or remind me how it's going to feel. Particularly for people with chronic pelvic pain, a pelvic exam hurts a lot of the time. And because it doesn't necessarily hurt for people without that kind of pain, the standard is just to do it the same way. But there needs to be a nuanced kind of care for people with chronic pelvic pain when you're doing an exam to make sure that the patient is comfortable, to allow them permission to say, this is painful.
The pelvic exam should contain an examination of the external genitalia, single-digit palpation of internal structures, bimanual exam, and speculum exam. On inspection of external genitalia, the vulva should be explored for lesions or skin conditions. A cotton swab should be used to assess for provoked vestibulodynia. A single-digit vaginal exam assesses for tenderness of the pelvic floor muscles and any nodularity. Bimanual exam identifies uterine size, position, tenderness, and mobility, and identifies adnexal masses and tenderness. A speculum exam may be performed to examine the vagina and cervix and take swabs if infection is suspected. People experiencing chronic pelvic pain should be sent for a pelvic ultrasound to explore possible pelvic pathologies, such as ovarian endometriosis/endometriomas, that may contribute to chronic pelvic pain. The patient can be sent for a pelvic MRI if deep endometriosis is suspected. Presence of multiple chronic overlapping pain conditions are suggestive of central sensitization, nociplastic pain, and should be identified and treated. These conditions include pelvic floor tenderness, painful bladder syndrome, irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome, and others. Central sensitization may be suspected when peripheral nociception alone is unlikely to explain the pain and/or when there are multiple chronic overlapping pain conditions present. Central sensitization has important implications for clinical management of chronic pelvic pain. Based on the comprehensive history, exam, and testing, you should have a better understanding of the contributors to the patient's chronic pelvic pain.
It is totally fine not to know everything, but the curiosity to learn and to practice how you're dealing with patients and to look at a holistic, wide view of how it's affecting their lives is crucial and something that I'm really excited for new practitioners to learn.
Watch the next video in our series to learn about the treatment of chronic pelvic pain.